This is headed by Jason Luoma, who's our principal investigator. Jason, you want to wave hello? A lot of you know Jason. So I want to inform you that today's presentation will be recorded, and everybody who's registered through Eventbrite will get a copy of the recording within a week after the presentation concludes. Christy is here as our tech support, so if you have any issues or questions, feel free to direct chat her. All right, so I'm really excited for today's discussion and panel of experts in the areas of psychedelic assisted therapy and research. I'm going to ask each panelist to introduce themselves, and we'll start with Sam Chapman.
Thanks, Brian. Hi, everyone. My name is Sam Chapman. I use he, him pronouns. I was the campaign manager for Measure 109. I've been working in drug policy reform, excuse me, for about the last 10 years of my life on medical cannabis, adult use cannabis, safe consumption sites, and now psychedelic reform and healing, specifically in the regards to Measure 109. I was the campaign manager. I now serve as the executive director for a newly formed nonprofit called the Healing Advocacy Fund, where we focus on spearheading the education and advocacy behind the implementation of Oregon's psilocybin therapy program.
Thank you, Sam. Next, we have Asia Molinar.
Hi, my name's Asia. I just recently graduated with my master's in psychology from the New School in New York, and I'm currently working with Ingmar and Elizabeth as part of Fluence as an assistant trainee, or trainer, assistant trainer with their trainings.
Great, thanks, Asia. And next we have Dr. Alan Davis.
Hi, my name's Alan. I am a clinical psychologist, and I'm faculty in the College of Social Work and College of Medicine, Ohio State University. I also work with the Center for Psychedelic Research at Johns Hopkins. I'm also a lead trainer at Fluence, and I'm happy to be here to talk about this new initiative in Oregon.
Thank you. And then we have Dr. Ingmar Gorman.
Hi there, it's a pleasure to be here. My name is Ingmar Gorman. I'm a clinical psychologist by training. Some of the past experiences I've had has been as a co-principal investigator with MAPS on their phase 2 and phase 3 studies of MDMA-assisted psychotherapy for PTSD. I've also been a therapist on those studies, as well as an assistant therapist on trials of psilocybin for depression. I'm also here primarily today as the co-founder of Fluence, which is a psychedelic education company. Elizabeth is not on our panel today, but she's in the audience. She's my co-founder. And what we're really interested in, motivated in, is educating clinicians, mental health providers, and others about psychedelic integration and psychedelic assisted therapy. So it's an absolute pleasure to be here and to be speaking to all of you.
Thank you. And then we have Kelly Sykes.
Yes, hi. Thank you for inviting me. I am a child clinical psychologist specializing in forensics in New York City. So a child forensic psychologist is really a parenting psychologist. And I became interested in how psychedelics could, some of the bridge points between psychedelics from a policy perspective, as well as how psychedelics might be, we might start to think about research with particular populations of parents with certain kinds of complex trauma and drug addictions or substance abuse disorders that have been seemingly resistant to certain treatment models. And that has large impact on their ability to parent or their ability to be with their children. So I'm very excited to be here today to talk more about some of the things that pertain to what we might want to start thinking about. Oregon is almost like a laboratory kind of for how we might start to sort of understand the intersection between how courts might think about psychedelics, accept psychedelics in the court system. So I'm very excited to be here and start this conversation with you guys. Thank you.
Thanks, Kelly. So just to briefly set the stage for today's panel, we'll be discussing the future of psilocybin-assisted therapy in Oregon, how research from clinical trials can inform the shape of how psilocybin treatment is implemented, and the role of psychotherapists and facilitators. We'll try to save some time at the end for questions from you guys, the audience, so feel free to type in your questions using the chat box throughout the discussion. But we'd like to begin today with a brief summary of the psilocybin initiative and recent updates from the Psilocybin Advisory Board. So Sam, we'd love to start with you if you'd like to give us kind of an overview of where things currently stand.
Yeah, absolutely. Thanks, Brian. Let me get ready to share my screen here. Let's see here. So, all right, can everyone see that okay? All right, great. So again, just a quick background on the Healing Advocacy Fund. As I said before, we're a newly formed nonprofit where our primary goal is to protect the spirit and intent of Measure 109 as passed by Oregon voters, and to ensure that this program is affordable, accessible, and equitable for all who stand to benefit from having access. That is certainly easier said than done. I'll be the first person to admit that. And it is certainly going to take a community effort to accomplish that. But that is the challenge ahead of us. And in my mind, it is a very righteous one, with everyone else in the country and the world watching Oregon to see how we develop this. So it really is an honor to be here to talk with everyone and continue to collaborate in this, what I believe to be a shared vision by the vast majority of folks that are probably on this call and working on this program. So Brian, I did focus mainly on implementation of the Psilocybin Advisory Board. I do have additional slides that I can go back to that do give a little bit of an overview of the measure itself if we need to. Hopefully people have a little bit of a general understanding of what the measure does not do. I'll be happy to entertain some of those higher level questions at the end as well. If there are gaps in people's understanding, happy to get people caught up. But to dive right into implementation here. So, and I'll give a little bit of a preface here on this. We have a year and a half now. It used to be 2 years, but time is flying by. We have a year and a half now to develop the rules and regulations in which the Oregon psilocybin program will be based on. And so these, in my mind, as I mentioned in the introduction, are really the three core pillars that will define whether or not we are successful in creating a program that is worthy of replication and that can really grow and evolve into something that can set the standard for not only other states to follow, but other countries around the world to follow as well, in terms of what a therapeutic program for psilocybin, and perhaps down the line for other psychedelics as well, can look like at the state level. So first, affordability. This is not a surprise to anyone, right? We need to ensure that the price and the barrier to entry is not created through a priced mechanism, right? There's a lot of very exciting things going on out in the world right now, from different type of technology that very well may make the cost of producing psilocybin negligible. And so then it's really going to come down to convening a table of facilitators, of insurance providers, of the state government, of philanthropists, and the people who really need access to psilocybin therapy now, to come together and really talk about the multitude of ways in which we can create access and ensure that affordability is not a barrier to entry for anyone who stands to benefit. So second, accessibility. When I think of accessibility, I think of a lot of different things, but from a political and policy perspective, in my mind, accessibility means geographic accessibility, right? So once this measure is fully set up with its rules and regulations, cities and counties will have the ability, if they so choose, to opt out or to develop time, place, and manner regulations. And I actually have a map that kind of shows the breakdown of Measure 109 votes per county, which is a little bit of a sneak preview as to what the checkerboard of allowed counties throughout the state of Oregon might look like down the road for services. And so we're going to need to have a robust conversation for the folks who live in rural areas where their counties may opt out and they may not have access within their localities to psilocybin services. And so I think it's going to be really important that we talk about the political and policy implications from a local, urban and rural divide type of mechanism. And of course, last but certainly not least, is equitable access and ensuring that our BIPOC communities throughout the state are centered in the development of equitable rules, regulations, services, and licensing. I think we have a lot of lessons right behind us from the cannabis industry to learn, tough, worthy lessons in terms of what equitable licensing actually looks like, and maybe more importantly, what it does not look like, in addition to equitable access to services, right? Which I think is going to be an incredibly important aspect of this program as well. And so again, these are the three core pillars for successful implementation as I see them. And again, this is a tall order, and we only have 1.5 years left to do this. I certainly wish we had more time, but it is the task at hand, and we have started to dive into the work, and I'm going to talk a little bit more about that now. Here is that map. Again, I'll be happy to provide this slideshow to Brian, so if you want to be able to upload so other people have access to this. I think this was broken down by the Oregonian right after the measure passed. But as you can see, we have a little bit of a checkerboard. No real surprise, Eastern Oregon wasn't super in favor of Measure 109, but I'll tell you, compared to cannabis legalization, there's a lot of new counties that turned online to this. And I think it really speaks to the fact that, you know, psilocybin services and this new modality and all the research that's coming out is really showing that, you know, the war on drugs is not as much of a bipartisan or a partisan issue as it used to be. And we're really starting to see a lot more openness to the conversation and acceptance, which I think is a good thing in terms of being able to provide services to as many people as possible, regardless of where they are. So, Psilocybin Advisory Board is made up of, I believe, 17 total members, 14 of which were appointed by the governor. This board is made up of many different individuals, from doctors to therapists to researchers to folks that have you know, indigenous and historical perspectives to bring to the table, in addition to community members and other folks that are starting to convene the larger advisory board at play. And so I'm going to go through a little bit of a timeline that is laid out in the measure, and then give a little bit of an update as to what subcommittees exist and what they're working on now. But the overall tasks of the advisory board are as follows. To collect existing studies, the research subcommittee is working on that right now, and I'll talk a little bit about that in a second. But essentially, the Psilocybin Advisory Board is tasked with making recommendations to the Oregon Health Authority for all license types and all rules and regulations for the program. And so there is a lot that goes into that. I'm not going to get to the depths of every aspect of that in this presentation, but there's a lot going on, right? From establishing public safety standards to professional conduct certification, training program requirements. What does the path to licensure look like for facilitators? When do we need to start training facilitators in order to meet our deadlines for the program being up and running? These are questions that really are getting fleshed out, and you know, we're really just still in the process of bringing everyone up to speed on the totality of work that we have. A lot of that work has begun, but again, this is a massive project, and the committees are really getting comfortable and getting to know each other, and the work has really just been starting over the last few weeks. And so these are some of the things that the advisory board is tasked with in terms of making recommendations to the Oregon Health Authority on rules and regulations for the psilocybin program. And again, so this is the statutory implementation timeline. There are many, many deadlines and timelines that exist within this, but for the sake of brevity, these are the timelines that are called out in the measure. So these are, we have to meet these deadlines by statute. And so as you can see right now, we're in this research phase. We're still collecting a lot of different information, and the research subcommittee is in the process of driving towards our first June deadline. And the goal is to collect all of the existing systematic reviews on psilocybin itself and psilocybin therapy as it has been studied over the last 50 and 60 years from a scientific clinical perspective, in addition to the thousands of years of experience and historical knowledge that can be brought from the indigenous perspective on how psilocybin and other ceremonial aspects of psychedelics have been played in as it relates to safety, efficacy, and delivery of those services. And so I think that they've been able to identify over 300 different articles that they are working on, essentially synthesizing into one overall collection of systematic reviews. And then the research committee will produce a very specific 2 to 3 page summary of, here are all of the aspects that are contained within this massive systematic review summary. Here are the questions that are still outstanding that we feel we need to tackle as we start to move into the rulemaking phase. And so we are really still in an information gathering stage. There's so much out there, and we're being very honest with ourselves about the fact that the purpose of this collection of data is really to allow the entire board to start from the same foundation of understanding about what we know, what we don't know, and how that's going to inform creating a program that, again, is as accessible, affordable, and equitable as possible for everyone who stands to benefit from having access. And so with that, well, I'll go through the rest of the timelines here. So that report is due June 30th to be submitted to the Oregon Health Authority. And then in July, the Oregon Health Authority will publish that report on their website for all to see. And that will continue to be a living document. The research committee is very excited to expand on the initial report that create, but they are also getting very diligent in just making sure that they hit the timeline and produce the product that can be updated and then can continue to be utilizing other people's information and research. We know there's a lot of research going on right now that we're not aware of or that has not concluded yet. That's absolutely going to be included in this overall compendium of research that has been compiled from around the world. And so it'll be really exciting to be able to take a look at that and for that to serve not just Oregon, but to serve other states and countries that are starting to think about how they might be moving forward as well. I'm sure if you're paying attention to anything in the news right now, there's many states that are already starting to move forward and replicating in whole or in part some of the Measure 109 model. And so having this type of baseline research for everyone to be able to access and contribute to is really going to be a global service to the community in terms of really setting the tone and the understanding of what we know, what we don't know, especially from a political and policy perspective. So with that, I will wrap up here. Again, I know there's probably a lot of questions, and I'm just going to yield my time to the other speakers, and we can get into Q&As at the end that you have. I'm sure there's plenty of good questions, some of which I'll have answers to, some of which I won't. But this is the current breakdown of the subcommittees that exist underneath the advisory board at large. So again, we have the research subcommittee that I've mentioned. The second committee is the facilitator training committee. This committee is focused on strictly defining the core minimum requirements for training programs to have in order to be certified as a training program by the Oregon Health Authority that future facilitators will go through. They will be able to do all of their competency curricula work through these certified training programs that will then apply for a licensure through the OHA, and that will be their path to licensure. There's a lot of details that have to be worked out in that process. That is a 100,000-foot view that I just gave you on that. There's, again, so much to be detailed out in that process. But again, the key of that committee, I think, is a priority right now in terms of if we want to meet the January 2023 deadline of having a program that's up and running, that means we need to start training facilitators soon. So they have the time to get properly trained. So by January 2nd, 2023, they can hit the ground running and applying for their license. And we have a program that is up and running and providing services in 2023. That is the end goal. Everything we are working on is driving towards that goal. Again, it's going to be easier said than done, but that is a task in front of us and what we have to accomplish. And so again, that is, in my mind, the top priority right now is being able to really determine what the core minimum requirements are going to be for the training programs, get them approved, get them up and running, and then really start to tackle some of the other major issues that are connected to that and others that are in different areas as well. And so that's facilitator training. We also have, the licensure committee, which involves the facilitator license. For those who don't know, there are 4 major license types under Measure 109. There is psilocybin facilitators, there are psilocybin service centers, there are psilocybin testing labs, and there are producers of psilocybin. Now, there very well may be variations or, for producing, for example, if you're using volatile extracts, there's probably going to be a degree of certification you'll need for variances. And I think we'll start to see what that looks like for the other license types as well. But those are the 4 main license types you should be aware of. The products committee is also off to a really good start, and just basically getting everyone up to speed on general mycology and how that works. There's a lot to consider in that subject as well, from genealogy to strains to fungal reactions that people have and allergies, to what dosage looks like and what that means for maybe a generally well-off and healthy person versus someone who may have underlying conditions or a diagnosis that needs to be considered, right? So a lot of really important conversations starting there. And last again, but not least, is our equity subcommittee, which has a robust number of members on it, some of which for Oregon. We also have many people from across the country that are serving on that committee. Dr. Rachel Knox and Dr. Angela Carter are the co-chairs of those committees, and they are doing a fantastic job in setting up that committee to really ensure that all these other committees, the advisory board at large, and the Oregon Health Authority at every step of the way are thinking about, are these equitable policies, right? And so it is somewhat of a checks and balances on the recommendations that will be made to the Oregon Health Authority. Again, that work is going to be some of the hardest and best work that's going to be done here. And we have a lot of work to do, but the creation of that committee and the folks who are leading it and the folks that are making up of it gives me a lot of hope that we can put our money where our mouth is when we said throughout the campaign and throughout this process that we really do truly want to center equity in this entire program. We have an opportunity, and that opportunity is ours to seize, or frankly, it's ours to lose. And either way, it's going to be replicated, whether we create a great program or not. We saw it happen with cannabis. It's going to happen with this too. So that is why we are taking our role in developing this program so seriously, is that we know whatever we create, it's going to have ripple effects across the country and around the world for decades to come. And so that's why it's so important that we get this right and that we include and center the people that we're really talking about that stand to benefit most. And with that, I'll go ahead and hand it back to Brian.
Great, thank you, Sam. Such a massive project. So I'd like to turn to Asia. Asia, I'm wondering if you could talk about some of the common expectations that people have when they use psychedelics and how they're taken into account with what's known as psychedelic harm reduction and integration. So maybe touching on both preparation and integration work.
Yeah, so, all right. One of the most common expectations that people have, and also maybe the simplest expectation, is just that people expect to have fun when they use a psychedelic. They expect to have a good time. Maybe they're at a party or a festival and they just want to have a deeper experience, and they want to feel more connected to others or make new friends. They might be, feeling some peer pressure if a friend asks them to use a psychedelic, and they might want to have, a more interesting or a heightened perceptual experience, especially when it comes to music and colors and light and things like that. People can also have the expectation that they'll experience some level of therapeutic healing. So if they're experiencing any issues with friends or family, like any interpersonal issues or any personal issues with work, or just maybe things like depression and anxiety, they might think that psychedelics are the answer to that, especially if they've heard about a lot of the things going on in the news lately about psychedelics. And maybe they've even read some research articles or news articles about how all these people are taking psychedelics and they're feeling much better and they're healing from their depression and their anxiety and PTSD. So they want to get in on that too. And I think that maybe psychedelics can give them the reset that they need, or give them the insight they need to address those issues. People can also have the expectation that they'll have an intense spiritual experience, and that it'll be extremely meaningful for them. It'll be life-changing, and their eyes will be opened forever. They'll be enlightened. And as part of that, they might also expect to have a mystical experience. So feeling that they're one with the universe and that they've transcended space and time, maybe experienced ego death, things like that. And then some people just might have the expectation that they'll get to know themselves a little better. They'll gain more insight about themselves and engage in some self-exploration. So I would say all of those expectations can be incorporated into both the preparation phase and the integration phase of PHRI, or psychedelic harm reduction integration approach. So in the preparation phase specifically, those expectations, a therapist should ask people what their expectations are and kind of get a gauge for what their expectations have been in the past and what they will be in the future, not only for their psychedelic use, but for integration. And those will essentially be turned into goals for both preparation and integration. And the therapist can also gauge what knowledge they might need to share with someone who's interested in using a psychedelic.
Yeah, thank you. Yeah, it's so important, the managing those expectations, and so much harm can be done when folks enter into the space without sort of knowing what to expect or having too idealistic expectations.
Right. And sometimes people have things come up for them during psychedelic use that they didn't expect, because, psychedelics can be non-specific amplifiers and can bring out emotions and feelings and memories that they weren't expecting to. So maybe they're taking it to have fun, but instead they have this intense emotional experience come up that could be stemming from a past trauma or some of their past issue. And the PHRI approach allows space for those types of things to happen and gives the therapist an approach to interact with someone who's had one of those experiences without judging them and without interpreting them in the therapist's own, by the therapist's own meaning. So yeah.
I think for probably a lot of folks here, we take, a lot of, it's sort of commonly known that, challenges could come up, past traumas can come up, a lot can happen. But for folks who are new to this, they might just read a headline that this is helpful for PTSD, and they don't realize that there's a lot of work, there's a lot of processing that's involved. So, I think that's really important to mention, Asia. So next, I want to ask Alan to talk a bit about some of the wisdom that we've collected from the clinical trials. What are some key takeaways from your perspective that can be helpful in considering how 109 is implemented here in Oregon?
Thank you. Yes, as part of my work in a clinical trial setting, I've provided psilocybin therapy to people, primarily folks with major depressive disorder, as well as working with some what we call healthy volunteers who are in our different trials. And some of the things that I think have been found, not only in the work that we've done at Hopkins, but overall, I think from the work that's been done up to this point, there are a couple of key takeaways that I hope are considered. And based on Sam's description, it sounds like a lot of that is already being considered. But one of them is really trying to determine who should be eligible to have this type of therapy. So thinking about the types of clients or patients that people are working with. And although we know that the research has been pretty conservative in terms of who should get into the studies, meaning that there's been a lot of oversight and kind of delegation of exclusion, if you will, by IRBs and FDA, saying that, we have to be very, very careful in these studies and exclude anyone with a history of, for example, psychosis or a risk for psychosis in their family. and other challenging features of their personality, like people with borderline personality disorder or other features that might interfere with developing a strong rapport. I think to the extent that we can be mindful of those things, at the same time, find room for relaxing some of this, given that we also know that there's a long history of safe administration of psilocybin in a lot of different contexts. And to date, there has actually been some new data published showing studies are starting to loosen some of these restrictions. For example, there was a study completed in San Francisco among long-term HIV/AIDS survivors that did allow people in with a little bit more flexibility in terms of some of the potentially challenging personality features that are just so common in mental health populations. So I think that hopefully the advisory board and the committees are going to find some flexibility and perhaps a little bit more openness, at the same time being mindful that we need to have proper screening in place. We need to have facilitators and centers who understand how to screen for these potential concerns and how best to determine whether or not someone should be admitted into a treatment. In addition to that, I think it's important to consider along those lines what that facilitator training is, and that we're not just training, people to not necessarily, in my opinion, not just to come in and be a good sitter, someone who's just going to be there and kind of monitor. I think that's a part of it, but we also, as Asia just talked very eloquently about, a piece of this process is helping to manage those expectations, preparing people, being knowledgeable about what these experiences are, and helping to prepare people for going into this type of experience. And this is different, I think, than managing some of the expectations of recreational use, although that they can be similar. But there are people coming in, to treatment settings who likely have tried a lot of other treatments. They've been probably disappointed or disenfranchised, or frankly, maybe even excluded from a lot of those treatments in the past. And so there's a lot of built up hope and expectation that this is going to be different. And that is important, and that might be potentially therapeutic in and of itself for them to have a positive experience with this treatment. But that's also a potential downside, because one of the things that we definitely know from the clinical research is that this is not a magic bullet. It's not going to solve mental health problems. It's not going to take away everyone's mental illness. And for some people, they'll experience a benefit for a while and they'll relapse. This is not going to end all of the people in this room's careers of treating mental health. However, it could be really helpful. But for those that it doesn't work for, I think we also need to be prepared for and thoughtful about how are we going to train facilitators to have those kinds of conversations in the integration phase. How are we going to help people when this treatment doesn't work for them? Now, that might mean that we have to have a more flexible approach to how many sessions people get and how frequently they might need those sessions. Perhaps, hopefully, in a I'm going to call it a post-measure 109 world, where maybe there's a new measure for MDMA therapy and there's a new measure for a lot of different options. Maybe it's a different combination of things that we can start looking at. And I hope that the research can that hope is something that is implemented. When this is implemented in a very short amount of time, can be as prepared as possible to navigate those things as they come up.
Yeah, thanks for mentioning that part, Alan. I think that's a lot of the wisdom why there's two facilitators, two therapists in the trials, is to sort of mitigate some of the risk for power imbalances. Of course, with 109, there's only needs to be one facilitator in the room. Do you have a sense? Can you say a little bit about what how therapists are prepared for that in the clinical trials and how that might be applied here?
Well, one of the things that's really nice about the teams that I've been connected to is that we typically have ongoing peer consultation and support with clinicians who typically have been involved in this type of work for a very long time and have had lots of experience navigating these things, which is especially helpful for new clinicians, or not necessarily new clinicians, but clinicians who are new to this type of work, to navigate these things as they come up. I think for a lot of people, especially those who've been in practice for any, number of years, you at some point kind of probably grew into some self-confidence about the work that you're doing and how to navigate, the work in therapy settings. And this is a little bit of a new thing, but maybe a lot of a bit of a new thing. And so just kind of being open to thinking about how are we going to network? How are we going to have consultation and built-in consultation groups around, people who are new to this type of work, so that they have the resources and access to get information and to think about how they can navigate these things. So thinking about how the centers are licensed and how that's comprised and what things might be, required in terms of the types of documentation of some of that, or at least the availability of that in the training of facilitators.
Yeah, great, thank you. Yeah, continuing on that note, in terms of training of mental health providers, Ingmar, I'm wondering if you could talk a bit about, what do you think are the important elements of training? You're a co-founder of Fluence, which you've had a lot of experience in training clinicians. So could you speak a little bit more about the type of training that you feel is going to be most important?
Sure, happy to do that. Maybe a good place to start, I'd like to offer a little bit of a respectful and balanced perspective on what's going on in Oregon, which is that, on one hand, the FDA is an essential part and plays an important role in terms of identifying whether a substance can be a medicine and can be doing that in a safe way. And so often people complain about the FDA, and there's some elements of that I understand, but it is there to keep us safe. On the other hand, as Sam has alluded to and Alan alluded to, psilocybin has been used for centuries. And so it's really important to also have that perspective. And so it's been believed to be a safe tool and also a sacred tool. And so in some ways, we could think about, maybe from the FDA's perspective, that perhaps this is premature in terms of the availability of psilocybin-assisted therapy. But if you take a more cultural, historical perspective, perhaps this is really, really late. And maybe from a democratic perspective, because that is how this has been passed, it's clear that people want access to this, this tool or this treatment sooner than later. So I think this context is actually really, really, really important, because it shapes and identifies the different stakeholders who may have interest in access to the treatment. And as for your question, Brian, some of those stakeholders are clinicians, are mental health providers. Of course, it's patients who want access. And again, as Sam very eloquently talked about, the importance of accessibility. That is something that is very closely connected to, of course, the training of therapists or facilitators, whoever will be there to accompany and support a person's process through the preparation, the administration, and ultimately the integration of these experiences. Now, to be clear, I'm here speaking on behalf of Fluence, and what we focus on right now primarily is the training of mental health providers, so licensed mental health providers. And I know that there's a very important conversation to be had about other facilitators who may not have a more traditional license. But for the sake of the conversation now, I'm going to be focusing primarily on that group. But I think a lot of these points actually apply across the board. And so when we're talking about training, one of the key elements that comes to my mind, particularly as we're talking about a transition to above ground accessibility, is a focus on the kind of therapeutic process. And so as Alan had mentioned, and Asia as well, when you look at a newspaper article or even sometimes a scientific paper, you can see sort of the outcomes, but you don't necessarily see the entire process, what got a person from the beginning of the work till the outcomes are measured. And something that we see, particularly as I practice in private practice, working with people who've had psychedelic experiences, is that sometimes people can actually feel a little bit worse before they get better. Psychedelics can be conceived potentially as a way of, this is maybe one model to think of, as sort of bringing things up rather than pushing things down. And in the process in which a person comes into contact with various aspects of, whether it be their psyche or different kind of changes that they want to implement, even ultimately when things go well, on the way towards that final goal, it can be kind of rough. And one of my concerns, or things that I think we really need to prepare clinicians and others for, is that sometimes this idea of things getting worse before they get better, sometimes refer to it as the unfolding process, is actually part of the process. And so to be able to do kind of a differential, to be able to recognize, okay, this person is not doing maybe well right now in the moment. They're maybe more vulnerable, feeling a little bit more emotional, processing things that happened to them in the past. But this is not necessarily a side effect of the drug, but we're rather part of the psychotherapeutic process. However, so training to do that is important, yet we also know that adverse reactions happen. They happen sometimes as a consequence of the intervention. Sometimes they happen just in parallel by chance. And I think particularly because of the shift in Oregon, I think we really need to be prepared to be able to identify, again, what is part of a process and what maybe needs a higher level of care or extra support. So in other words, one of my concerns is I would hate for there to be a moral panic as a kind of reaction to some of the potential adverse reactions that we kind of can expect to happen. And for this whole project to get shut down, I think that would be really unfortunate. Another aspect of training, I think, is really working with clinicians to understand and be open and curious. And I think that many of you here in the audience will probably be like, I'm a therapist. Of course, I'm open and I'm curious. That's sort of that's what I do. That's my forte. However, even to our best, and I include myself in this group, even to our best kind of abilities and our best intentions, we're also always formulating interpretations. We're trying to figure out what is going on, what will be helpful. And when it comes to psilocybin work in particular, it's really important to really take a step back from trying to apply some sort of our own filter or map or understanding of what's going on for the participant, or in these cases, clients or patients, and really help them facilitate for them their own understanding of what this experience means for them, that there isn't necessarily one kind of experience. There's a lot of attention towards the mystical experience or ego death, but not everybody has that kind of experience. And just because they don't have that experience doesn't mean that the treatment is not necessarily, or is not working. And so clinicians really need to be prepared about for their own expectations in terms of what they hope for their clients, as well as helping prepare their clients and patients to be really open and receptive that this experience may not be what they expect, or in some ways may be very, very different. What I mean by that is sometimes it may not live up to their expectation. In some ways, it may far exceed their expectations. Roland Griffiths had talked about this term ontological shock, which I'm a big fan of. Really kind of a complete shift in a person's worldview. And the repercussions of that are not just within the psilocybin dosing session, but in the integration process, where we're helping a person really adjust to potentially a very dramatic and quick change in their value system or in the way that they see the world. And so maybe I'll just stop here and say that these are some of just a few of the elements that we bring into our training at Fluence. And something that we really hope we're offering now as part of our training as it relates to psychedelic integration work, which people can practice now, even though they're not administering psychedelics. and as well something that we really emphasize when we begin to train in psychedelic assisted psychotherapies proper.
Yeah, great. Thanks, Ingmar. As a therapist in the community, one thing I hear a lot from clinicians is, how do I get involved now? What can I do? It sounds like there are options. I don't know if you have anything more that you want to add about, are there things folks should be considering now? Should they wait and see what 109 says?
Yeah, and I want to keep this very short because I want to be respectful of Kelly's time, which is that, I think many people are really excited to have an opportunity to be a psychedelic assisted psychotherapist or psilocybin assisted therapist, administer the psilocybin and be with somebody throughout the entire process. But I think it's really important to remember that people are having these experiences right now. They're going to Peru or South America, Central America for experiences. They have underground therapists in some cases, or they're doing it with friends or at parties. And when we do an assessment as a clinician, we often ask about trauma history, substance use history, psychosocial, but we often tend to neglect psychedelics, even if we are doing a substance use history. Think, well, they're not typical substances of abuse. Yet we also know from research that in one study, participants who received psilocybin rated it as one of the top 3 most important experiences of their life. We're not even asking questions about this. And so there's so much I think that clinicians can be doing right now, despite not actually handing or administering psilocybin. And that's something that we at Fluence have been working on. It's how I practice in private practice and something that we've been training for the last 3 years. And in fact, I'll share this, my colleague Elizabeth will share it in the chat, but we have a paper that's been published called Psychedelic Harm Reduction and Integration, which is a trans-theoretical model for clinical practice. It's open access. You can read it. It goes into a lot of depth about our approach. And I really want to emphasize the trans-theoretical word underline, because we're not dogmatic here about a particular orientation. We know that you all as clinicians already have skills, and this is just really more of a lens that you can use in order to kind of bring your strengths and apply it to people who are having or have a relationship with psychedelics.
Thank you, Ingmar. So Kelly, I'd like to ask you, as a parenting expert working in the courts, what factors should clinicians engaged in psychedelic therapies consider if they're counseling court-involved parents?
Sure. So I think what's really helpful is to understand how the court perceives danger and risk in a child protection population or parents who might be under investigation. So any kind of altered state can impact, from the court's perspective, can impact parenting, right? Parental judgment. So that could be mental illness, it could be substance abuse, it could be, well, those would be it could be trauma, but anything that alters parental judgment is what the court perceives as risk or threat. And so what is perceived as normal use outside of an investigation can be perceived as abuse or misuse inside of an investigation. So the court is very concrete and abstinent based because they don't have the ability to be nuanced in this idea of, we have no way of knowing if the person was, if once a parent is flagged for any kind of parenting issue, then their judgment is already under scrutiny. So then anything they do is now under scrutiny. So anything that is perceived as subversive, so using marijuana now becomes a potential risk to the child, even though it might be normal use of marijuana. So for this reason, harm reduction virtually doesn't exist from a court perspective. They don't have the ability to take in that kind of nuance. So so when you're talking about altered state, or you're talking about, which again, from a child protective point of view, that could be a parent who has mental illness, drug addiction, and now we have possibility of use of psychedelics, which is, you know, a type of altered state. The court is not able to, so I'm sorry, I lost my train of thought. So any clinician who's considering work with these kinds of, with parents who might be under investigation should have these things in mind, first of all, in thinking that do not assume that because it's legal, that it will be, that the court or the caseworkers or the people involved in monitoring this parent is going to perceive that as appropriate or clinical respectable treatment, simply because of the element of altered state. And remember that the drug laws we know that the drug laws have had a disproportionate impact in the criminal realm, but it has also had a disproportionate impact in the child protective realm, right? So there's a parallel in terms of parents being perceived as threats because of positive drug testing, or because they are not abstinent with any, even methadone, even use of methadone or boost barb, things that have been known to be treatments for certain kinds of opioid addictions, are still considered unacceptable in terms of this altered state, this compromised judgment. So that's very important that people keep that in mind, first of all, that there's no assumption that use is going to be perceived as the same thing under investigation. The second, so one of the things that you want to think about in terms of, informing and talking to your clients, is first of all, any clinician who might be doing this kind of intervention or referring their client to this kind of intervention, you want to make sure that it's a licensed clinician, that all aspects of the treatment follow what we know are best practices, that any kind of referral or treatment model, that psychedelics are being used in accordance to what we know the research has already shown to be effective. So we know that for PTSD, for substance abuse, for certain kinds of mental conditions, that there's a strong empirical basis. And so you wouldn't want to make a referral for a psychedelic intervention that's something to the effect of to help the parent work on their relationship with their child, or to help the parent manage their anger, because we don't have empirical, or to improve their attachment relationship with their child, because there isn't empirical evidence for that. So at this juncture, any kind of consideration, after you know all of these things about how the court might already perceive altered state, you want to make sure that you're using psychedelics in the way that they've been shown and researched to be effective. And you want your documentation, because remember, your records could be subpoenaed. So you want your documentation to very much follow, what your licensed profession says are best practices and what should go into documentation, your treatment goals, and how this aligns with the treatment goals. But you definitely want to make sure that if any parent who's under investigation who might be considering this, that the clinician be prepared to speak with their caseworker, their attorney, any of the people who are involved in their case, that they should have a fact sheet with references developed and ready. But the only way empirical information, research gets into the court is via experts, right? The attorney can't, for example, point to all of the research that exists that says that this is an effective treatment. The attorney has to say that the parent's therapist has this kind of training, has this kind of has this kind of information, can provide this kind of empirical data to support the treatment intervention. So any clinician who's working with a court-involved parent, they're almost obligated to ensure that they have there's some kind of certification in doing that, and to be licensed and to be operating within a frame of best practices. And I think those are some of the, and really important to know about drug testing and how psychedelics, what the specific psychedelic or psilocybin shows up in drug testing and what that might mean.
Yeah, thanks, Kelly. It's so important. You know, what comes up for me as you share is the larger topic of stigma. And even though, you know, psilocybin treatment might be legal, you know, Sam showed that map in a lot of parts of the state. People may look down on this. You know, are you going to be able to share with your doctor? Are you going to have to keep this from your coworkers? So it's good for us to be thinking through all the implications.
Yes.
So I know we're about out of time. I don't know if any of our panelists have any final contributions that they're just dying to jump in with. Anything that we really left out, or anything anyone want to say?
I just want to say something very quickly in your last point, which is stigma, not just for the clients, but also for ourselves. You know, just think very carefully about what it means, the culture of your institution or the culture that you're in. This is a sort of a pretty dramatic shift, and just be mindful of how it might affect you to speak about not that you should perpetuate stigma by not talking about it, but also, you know, be careful about the impact that it might have on you as a clinician as well.
And one thing I'd like to just highlight was something someone said very early on today, which was Oregon is a testing ground for this. And the implications of that are potentially immensely positive for the nation and the world. At the same time, there's been a lot of work to get to the point where this type of initiative could even get passed in terms of the decades of research and a lot of diligent work that's gone on. So please remember that and take on that responsibility as agents of change in your practice and in your communities, and know that you know, it has wide-reaching implications.
All right. Well, thank you everyone for joining us today. We'll be emailing you a recording of today's presentation within a week, so be on the lookout for it. If you don't get it, feel free to email us, or if you have any questions. Be sure to check out Portland Psychotherapy's upcoming presentations and workshops. We're having one last TRIPS event this summer on June 11th, Becoming a Psychedelic Informed Therapist, toward developing your own practice with Nathan Gates. So it's good to see you all today, and be well. Take care.